So yeah, I'm not at home, and Mr. Peanut's on a timeout. He was being a naughty little dinosaur. But I mean, it's just like when someone asks me like, should I get a cockatiel? I'm like, oh yeah, they're really great companions, but they, just like people, they have their moods. Anyway, let's get on with today's lecture. So today's lecture, we're going to continue with the heart. So what we have here now, we left on talking about those valves and how they maintain the directional flow in the heart, meaning that your chamber blood should flow through the chambers of the heart in the correct order. So again, it should be blood flowing from the right atrium to the right ventricle, and from the right ventricle into your pulmonary trunk and pulmonary arteries, and the left atrium receiving blood from your pulmonary veins, and then the left atrium moving blood into your left ventricle, which the left ventricle pumps blood into the aorta and the rest of your body. Now, the valves, what do they sound like? Yeah, so those are our heart sounds. So when you use a stethoscope and listen to these heart sounds, that's what you're listening to. You're listening to the sounds of those valves closing. So when it's kind of like slamming a door shut, when you slam a door shut, that makes a noise, right? Well, same with your heart's valves closing. Now we have to talk about these terms, systole and diastole. So what are those terms? Well, my mnemonic for those are, so systole is when you have contraction. So remember that the cardiac, well, it's not all muscle, but the muscle is the part that enables the heart to pump blood. So systole is when the heart is contracting and all the cardiac muscle is contracting. So my mnemonic is systole squeeze. So again, S and S. Systole squeeze, so your heart is contracting and squeezing the blood. And again, depending on the chamber and depending on the side of the heart, where it squeezes blood, that's why you need to know your chambers. Now, diastole, so diastole is the exact opposite. Instead of contracting, just like how with your muscles, like unless you're going to having wicked cramps or tetanus, you also have to relax your muscles. Same with the heart. The heart not only has to squeeze and contract, but it also has to relax and dilate. So diastole is when it dilates or relaxes. So my other term mnemonic for that is like diastole is the downtime. So again, systole is when the heart muscle is contracting and squeezing. Diastole is the downtime, and dilate. So again, dilate is that useful word, like saying something getting bigger in diameter. So it's not just like the heart walls and the inner chambers of the heart. Like this is a useful term when talking about blood vessels as well. Now, lub and dub. So the first heart sound, S1, and there are other heart sounds, but for this class, we are just going to concentrate on S1 and S2. If you're going on to nursing or medicine, you'll have to learn about S3 and S4, but I think that's an extra topic. Your TA may or may not talk about this, but for this class, the lecture definitely know S1 and S2. So this is when your mitral and tricuspid valves close. So these are atrioventricular valves, and again, go back to the previous lecture, these are the valves that connect the atrium to the ventricles. So these are the ones that maintain that flow of blood from the atria to the ventricles. And why are they closing? Well, remember that the ventricles, when they squeeze, they're going to increase their pressure, but these valves are trying to prevent blood from squeezing from the ventricles into the atria. So this is due to these AV valves shutting, and that's due to the choroidal tendineae and papillary muscles helping to anchor those valves and preventing them back flushing and blowing out the wrong way. So it's from these valves snapping shut due to that increased pressure that causes that first heart sound. And again, we have a mitral and tricuspid because we have left and right side of our heart. Now, this is the start of ventricular systole, again, systole squeezing, increasing that pressure, but you don't want that increased pressure to push blood back into the atria. So that's why it's the AV valves that are closing. Now, the second one is called dub. And yes, there are other spellings, like sometimes they have the double B, sometimes they, instead of lub and dub, they have lup and dup. It's kind of like that Korean letter bup, where it's kind of like sometimes it's written as a B or P. Doesn't matter, I don't care which one you use. They're but they're called lub or dub or lub but dup, some whatever. Like this is the S1 and S2. Depends on your textbook. I don't prefer any of them. Just know that there are other spellings, but not right now. Okay, so again, semilunar valves are closing. So this is a different set of valves. So the AV valves are your mitral and tricuspid valves, whereas your semilunar valves, these are the ones that are going to your great vessels, your pulmonary trunk and your aorta. So those are closing during the S2 sound. So instead of ventricular systole, this is actually ventricular diastole. So what's happening is that the ventricles are enlarging and relaxing, so the pressure is going to drop. So if you've ever been like in a room where it's very windy outside and then the pressures are changing in the rooms and sometimes the door just shuts due to the movement of wind outside? Kind of similar in ventricular diastole. So it's again due to these valves shutting, but it's preventing blood from going back into the ventricles while they're relaxing, because again, if the ventricles are relaxing, that means that there's less pressure in there. So that means that's the pressure drop would attract the blood back into the ventricles, but since you have that aortic or the pulmonary valve, that prevents the back flushing and regurgitation, so those valves shut. Alright, so lub or dub, I now have the double spelling here. So what this is happening, this first heart sound, those are the AV valves closing. And why? Because again, the ventricles are squeezing over here, so you don't want blood going back into your atrium. So these valves, due to them snapping shut, that causes the first heart sound. Now dub, that is due to the other set of valves closing. So we have the aortic and pulmonary valve over here. So again, this is preventing, now that we have the downtime and diastole with the ventricles, there is a pressure drop here, so there's now less pressure because the ventricles are expanding, but you don't want it to suck that blood back into the ventricles. So this is why or not AV valves, ooh, caught myself. That's why the aortic and pulmonary valves close. So that's why it's preventing that. Okay, so this is how do you listen to these heart sounds? Well, you can get cheap stethoscope unless if you get into nursing school or med school, you can buy them fancy ones, but you can just use a very cheap ones. Like they have cheap ones out there. But how do you do that? Well, the thing is that why do you do this process called auscultation? Or in other words, you're kind of listening to these sounds, and you can also listen to other sounds of the body as well. You can listen to your GI tract, you can listen to your lungs, but in terms of the heart, why is this useful? Why is a stethoscope useful? Well, the cool thing is that, like, depending on where you place the stethoscope on someone's chest, you can listen to the different valves. So if there's something like some sort of valvular defect or something wrong with the valve, you can hear different things, or sometimes different types of pathologies for valves have different sounds. Now, I don't expect you to know the different pathology sounds because, again, there's no sounds on these tests. But this is why it's very useful to know your anatomy, and because it's depending on where you put this is where you can listen to the different valves, just different based on the placement in the chest. You also can listen to that if you suspect, but again, this is an easy thing to do because you don't have to poke anybody, you don't need to inject anything. It's pretty non-invasive to do this auscultation. Okay, so we talked about the inside of the heart. Now let's talk more about the outside parts. So what we see here, oh wow, we have a lot of structures here. So we talked about the chambers. Now let's talk about all these vessels and everything. So what do we see here? Well, what's the big differences between this and this? Take a few seconds, think about it. Okay, one's a drawing, one's real. Two is that you might notice that, yeah, you have the vessels, you have the major big vessels here and the major landmarks. But one thing you don't see in this cadaver heart is you don't see this yellow, off-white corn looking stuff, right? And that is adipose. So the thing about the heart wall, so remember we talked about the different layers of the heart wall, and we have that going from superficial to deep. You have the pericardium, and then you have that little space called the pericardial cavity, which is exaggerated in this case, the epicardium, and then the myocardium and the endocardium. Now, the thing about the pericardial cavity, and this is the part that I didn't tell you the last lecture, is that it's actually continuous with the epicardium. So what we have here is an analogy from the Martini book where it's talking about how the pericardial sac and the epicardium are kind of like punching a balloon. So the heart is supposed to be the fist, and the epicardium and pericardium are supposed to be that balloon. But again, what they're trying to tell you about this is that there's a inner space between the epicardium and pericardium, but they're not two different layers. They're actually one continuous layer you see here. So the thing about this is that, yeah, it's not just like a separate layer, it's actually a continuous layer, and it wraps all the way around the heart. So even though you have the pericardial sac, it's not a separate layer of connective tissue. and it actually has this pericardial fluid. Now, not as big as this volume here, but it does have some fluid to help with lubrication, because it's kind of like I like to liken it like a kind of rash guard for your heart, because your heart is always kicking and contracting within your chest. So this also forms a protective layer. And certain diseases, sometimes you can get infections of this, or too much fluid builds up and starts to restrict the heart, but that's a little advanced topic. Maybe your pathophysiology class in the future will cover. Yeah, so this is my main point. The pericardium and epicardium are continuous. So yeah, that's why I'm showing with this picture over here. Now, epicardial fat, and that is one of the big differences with the two images. The drawing had the adipose, as mentioned in the chat, but what we saw with the cadaver heart is that all the adipose has been cleaned off. Now, typically in a patient, you'll see some I remember there was one person who donated their body, and they said that they were a triathlete or some sort of athlete, but yeah, they had almost minimal epicardial fat. But typically, people who donate their body to the medical school, it's a very common thing to see epicardial fat. So where this is between the heart wall and the pericardial sac, and that's what we see over here. All this fat shown over here, but it's not just in the epicardium and the pericardium. It can be in different. Is it on the outermost layer, or is it on the innermost layer of that pericardial sac? So what it does is it's very important for cushioning. So remember that white adipose tissue is more than just nutrition storage, but it also they sometimes call it the packing materials of the cell or the body, because it's soft and it's able to cushion against physical forces and stresses. But the thing is that when you have someone who has a high body fat percentage and obese BMI, or if they have an increased risk of heart disease, and this is a link between increased adiposity, or what we call increased body fat, and heart disease. And thing is that, okay, so this one I put an asterisk. I don't expect you to know the differences, but I'm letting you know that if you look at epicardial and pericardial fat, even 1 year ago, I have to look at this every year, because I don't think there's a consensus yet. Some older textbooks actually consider it the same, but this is what I've noticed so far seems to be almost the consensus, or it seems to be leaning this way. So epicardial fat seems to be, okay, this is the part that's within that pericardial cavity over here, and this is more closer to the epicardial layer, whereas pericardial fat seems to refer to just anything involving the pericardium and that pericardial cavity. So it seems sometimes there's other textbooks that just say pericardial fat is just this outermost layer and not this innermost layer. So don't worry about for this class, but just FYI if you're interested in this stuff. Okay, so fat distribution. This goes all the way back to our endocrinology talk and about obesity. And remember this whole thing with the apple and pear shape? Do you tend to accumulate fat around the thorax and abdomen, or do you tend to accumulate it around the hips? And what's happening with this one, the apple shape, so to speak, is that they have more visceral fat. And again, viscera is that key word that means organ. So that means that these people tend to accumulate fat around their organs, including the heart. Now, people with this pear-shaped sort of fat distribution is that they tend to be subcutaneous. So not really about the organs, but more about the limbs and having fat underneath the skin and dermis. So what we see is depending on where you distribute fat, again, people who have this more their fat distribution more toward their thorax and abdomen tend to have more epicardial fat, whereas people who have this sort of shape over here, the so-called pear shape, and this more subcutaneous fat distribution, they tend to have less epicardial fat. So this is why, when I should go look up how do they actually, maybe it has to do with waist and hip measurements. I have to look at more how they determine who's an apple, who's a pear. But they see, okay, people with this more abdominal distribution, they tend to have increased epicardial fat. So this is why it's not just about how much percent of fat you have, but where you also tend to accumulate this fat. Now, why might it be unhealthy to have excess epicardial fat? You might be like, okay, so yeah, why is that? If it's cushioning, then why might that be not a good thing to accumulate too much fat along these parts right here? Well, now we have to talk about more anatomy, but now we're going to talk about the anatomy of all those vessels. So here we have our great vessels over here, but notice that from the aorta, you have at the very base of it, so just immediately after you squeeze blood from the left ventricle, just right past the aortic valve, you have these little two parts right here that branches called the left and right coronary arteries. And they also branch into further branches and smaller branches, as you can see here. Now, coronary arteries, so your blood is always circulating within the chambers of your heart, but the thing is that within your chambers of your heart, the heart is swirling this blood, but does that necessarily mean that it has enough time for all the oxygen and nutrients to offload from the blood swirling around in your heart towards the rest of the tissue layers in the heart? So coronary arteries are very important because they are your heart's own blood supply. So that means your heart is a muscle, therefore it's spending a lot of energy, and therefore it needs a lot of oxygen and it needs a lot of nutrients. Coronary arteries are very important because they're the vessels that supply your heart muscles and heart walls with blood and nutrients and oxygen. Now, the right coronary artery, there are main branches to it, and they're also like when it goes around toward the posterior and starts going down toward what we call the apex. We call the posterior descending artery, or PDA. The left coronary artery, the two main branches of those are the LAD and sometimes called anterior interventricular artery. I prefer LAD. But you should know both because like sometimes it depends on the textbook or paper you're reading or or sometimes the surgeon you're talking to. But I like LAD because it tells you exactly where it is. It's going to the left, it's anterior, and it's descending. So I love LAD because it tells you exactly where it is. The circumflex. Now, whenever you see something called circumflex in general anatomy, most of the time, and there might be a few, I have to think about exceptions, but what we have with the circumflex artery is that kind of wraps around. Just like when you have a circumference of a circle, that's the length around the circle. A circumflex means it's kind of like doing a U-ey or it's boomeranging around somewhere. So the circumflex artery wraps around anterior to posterior. So those are the two main branches of the left coronary artery. Now, why do you need coronary arteries? Again, you do have blood on this inside chamber, but there's not enough time and it's not very efficient to carry all the oxygen nutrients from here to the outside. So what the coronary arteries do is actually have these blood vessels that go through these layers and they distribute blood to these other layers of the heart. So that's what we have with this coronary artery that's perfusing the so it's in the epicardium, and then it branches off further and further into the myocardium and endocardium. So this is why the coronary arteries are super important, because they're important for keeping these blood vessels, or not blood vessels, but your heart, the walls of your heart alive and kicking. Now, how do you get that blood into there? Well, the thing is that we have our heart and when our ventricles are contracting, especially our left ventricle, that moves blood up into our aorta. But remember that the ventricles also relax, so this is why our valve shut. So the blood wants to go back due to the difference in pressure, but now we have the aortic valve preventing the regurgitation and back flushing of this blood. But with this valve, if you have any pressure over here, this is also going to move blood, so now we have our aortic valve closed, right? So either the blood stays in here, or some of it can actually end up in the coronary vessels, and it does. So this is why the aortic valve is also important, because this is important in directing blood flow to the coronary arteries. Now the left coronary artery, again, is going to split further into the LAD, the left anterior descending artery. Again, one of my favorite arteries because in terms of naming, because it tells you exactly where it is left descending, or left anterior, so in front, and descending. Circumflex artery, so that's not the entire circumflex artery, because again it wraps around. And you have the right coronary artery, so the right coronary artery is to the right. Now, there's also something called the right marginal artery, and right marginal artery is cradling the inferior part of the heart right here, going toward the point of the heart, what we call the apex. And let's look at the back. So if we look at the back of the heart, so that circumflex artery, so again, that front view doesn't show you the entire circumflex artery. There is a back part to it. Now there's a left marginal artery, and then that's a branch of the circumflex. The right coronary artery is continuing to wrap around, and there's also that right marginal artery as well. But there's that posterior descending artery, and another name for it is the posterior interventricular artery. So with this one, what it means is interventricular, between the ventricles. And with the LAD, the alternate, or in the other side, notice that it also is called the interventricular artery, meaning that it's between the ventricles as well. So yeah, so you should know both names for that, at least the LAD and PDA, because again, sometimes different textbooks or different professors or different surgeons might prefer one term over the other. Okay, so these are the ones I definitely want you to know. So all of these listed, these like circumflex, the LAD, the right coronary artery, and the PDA, you should definitely know all of these coronary arteries. Now, coronary veins. So remember that arteries are not necessarily, in this case, they do have oxygenated blood. And if you look at their color coding, they are red. But remember that arteries and veins are not so much about what their contents are, but their directions. So notice that they're carrying blood. It's kind of interesting. Carrying blood away from the heart, but now it's supplying the heart with its own blood. So technically it is carrying it away from the heart. Now, away from the heart to its own tissues. I think I'm starting to confuse myself with this stuff. Okay, so then coronary veins. So if there's an artery, there's a match. You need veins. So you have the artery supplying fresh oxygenated blood to the heart's tissues. Now you also need veins to collect the spent blood that's deprived or that's been robbed of its oxygen and nutrients, and collects all the waste and bring it back to circulation. So this is going to be the return. So again, the arteries are delivering stuff, but now you're going to want to get rid of the wastes. So these are the main coronary veins, and all of them drain into something called the coronary sinus. Now, instead of having those like systematic names, they have like great, small, and then middle cardiac vein and posterior cardiac vein. So they're a little less intuitive in describing how they're shaped or how they are arranged. So the great cardiac vein is the one that's associated with the LAD. And then the small cardiac vein, this is more associated with the right coronary artery. And then you also have these anterior cardiac veins, and why am I kind of like not emphasizing them as much? And in terms of like where they are, yes, they tend to be anterior, but depending on like, there might be not just only 3 of them, there could be multiple type, like 4 or 5 of them. So this is why I'm not focusing on them as much in terms of knowing exact locations, because these can be pretty variable. Now if you look at the posterior, what we have is that small cardiac vein wrapping around again, and then we have this great cardiac vein, and then you also have something called the posterior vein of the left ventricle, and I de-emphasize it because sometimes this also has other names as well. But you also have this middle cardiac vein, so this would be paired with that PDA. But where do we notice? Well, so what all of these veins have in common is that they drain into this common structure over here. So this one, if you look at the original image, is pretty thick compared to the veins, and this is what we call the coronary sinus. So it's kind of like a reservoir that collects all the spent oxygen poor with all the waste and all the carbon dioxide that's accumulated from the metabolic activities of your cardiac muscle. So this is going to collect all of that spent blood and put it back into the right atrium. Now, let's go back to our epicardial fat, and why is it unhealthy? Well, where do we look at all that? We just talked about those vessels. What do we notice is surrounding all these vessels? We notice that all this epicardial fat is surrounding the vessels. So if you have too much of this fat, that can also affect the vessels as well, because remember that fat is more than a nutrient storage, it's also endocrine as well. So the interesting thing is that why is fat dangerous for blood vessels? Well, here's a normal artery, and this is what you would see if you just took an artery, did cross section, and looked at it. So this in the inside, and a normal artery should be completely smooth, completely open. But if you have too much fat in your circulation, what can happen is that you can end up developing lipid deposits. So that means it's kind of like having your pipes clogged up with all this fat. And what happens when your pipes get clogged up with fat? That impedes flow, and that same thing happens with your coronary vessels. It also has to do with fat transport, but we get on to that. We talk more about that later on in the semester, but this is why having high concentrations of fat is unhealthy, because again, you want blood flowing to all parts of your body. You don't want any part of your body deprived of blood. So this can happen with having too much lipids in the body. And what you notice is that this cross section, now you have less blood flow because this open space has been closed off. Now this, if it gets bad enough, then you can have something called ischemia. So what is ischemia? So ischemia is impaired blood flow, so you have decreased blood flow to a tissue. And why is that bad news? Again, blood contains the things your cells and tissues need to live. So basically, just like you, your cells also and tissues need oxygen. And if you have ischemia and reduced blood flow, you're not also getting the nutrients, things like glucose or fatty acids or amino acids that can provide your cells with energy. So you don't have oxygen and you don't have the yummy nutrients that your cells need. So again, your cells are like you need oxygen and food, so do your cells. And the thing is that with this decreased blood flow, you're also preventing not only the good stuff from getting to your tissues, but you're also preventing the waste products of your tissues' activities from being carried away. So this is why ischemia is bad news, because again, you're not getting good stuff, but you're building up the bad stuff. So cells, if it prolonged for long enough, then the cells can eventually die, which is going to cause your tissues and organs, and if it's bad enough, it could cause you to die. So this is why cardiac ischemia is very, very, very bad news, because why? Well, what happens is that, do you want your cardiac cells to die? Yeah, your heart is beating constantly, so if something's affecting your heart, it's going to affect your life. So what we have here is occlusion, means that it's being blocked off, and what we have here is it's like a traffic jam, right? If there's a big rain and all these boulders fall into the street, can cars get past that boulder and blockade? No, right? So what's happening if this coronary artery is completely blocked off? You can't get blood flow to this area, so these areas are going to die off. Now what we have here is damaged heart muscle, but if this stays, say this occlusion stays in place, this is going to die off eventually, because why? No oxygen, no nutrients. Therefore, everything downstream of that can't get its supply of those essential gases and nutrients. So again, your heart is constantly beating. Again, it's just you're constantly circulating the blood throughout your body, delivering oxygen, delivering nutrients, delivering everything your cells need to keep alive. But the thing is that, what if a coronary artery is blocked by these clots or plaques, or things like, remember we talked about embolisms when we talked about the coagulation cascade and clot formation? Well, what if you have something blocking your coronary arteries? And well, if you don't intervene, it can result in something called a myocardial infarction, also known as a heart attack. So the myocardial infarction is a medical term for what's commonly known as a heart attack. So that's what's happening during a heart attack, is that one of the coronary vessels we just talked about is being blocked, therefore causing part of the whatever. And which part of the heart dies depends on it all depends on which coronary vessel is being blocked at that time. So yeah, ischemia results in, so again, ischemia, it's not just about the heart, but we're talking about, in general, ischemia refers to decreased blood flow to tissue. So it can apply to other tissues as well, but in this term, with the myocardial infarction, we're talking about ischemia to the heart. And what happens is that the cardiac muscle, if this occlusion stays in place, all of this heart muscle is going to die downstream of that occlusion. Yeah, so this is why we have our coronary arteries, and again, depending on the part, so if you have something like occlusion in the PDA, it's going to affect this part of the heart over here. If you have something like saying affecting the right coronary artery, it's going to affect everything downstream over here. So it all depends where this occlusion occurs. And let's go to a quick top hat question. All right, now things have probably changed in the time since, because again, due to obvious reasons, something else started to affect the causes of death in the United States. But pre-pandemic, what was not heart disease was a number, where do you think it ranked? So yes, this is pre-COVID. I have to actually look up where it ranks now. Okay, so pre-COVID, it was, so most of you said it was the number one cause, and yes, before the pandemic, everything was, or heart disease was the number one cause of death in the United States. And this is why it's very important to know about heart disease, because again, it's like, well, your heart has to stay alive and it has to keep kicking, so this is why you want to make sure it stays alive and functional as possible. Alright, so then there's something called the Widowmaker. And when you have, or a Widowmaker heart attack, so it actually involves one of those specific coronary arteries. So when you have the LAD being blocked, this is the deadliest type of coronary occlusion. And why is that? Well, it's like, okay, we know all the coronary arteries supply blood to the heart, but depending on which coronary artery it is, it supplies different parts of the heart. Now, when you look at the coronary circulation and coronary arteries, well, where is the LAD? So the LAD is that anterior interventricular artery, so it's going to be between the ventricles, but the LAD is also important in supplying the left ventricle. So it does supply both ventricles, but especially the left ventricle. So remember, where does the left ventricle, well, what does the left ventricle pump? So what about the blood? Is it oxygenated or deoxygenated? And two, where does the left ventricle pump the blood to? So what's its job? Where is it trying to circulate its content to? Well, remember that the left ventricle is trying to circulate all the freshly oxygenated blood that just came from the lungs. So it has oxygenated blood, and again, your body needs oxygen. But where is it going to pump the blood to? It's going to pump it up into the aorta, which branches off to the rest of the body. So if you have the LAD being blocked off and this left ventricle dying and being affected by the ischemia, well, that's going to impair the blood flow of oxygenated blood to the rest of your body. So this is why the LAD is called or why it's called Widowmaker heart attack, if you have the LAD blocked off. And this is why it's the most lethal type, or frequently lethal. But what we have here, so again, it all depends on where it's going. So remember, the right ventricle, you can have a heart attack affecting the right side of the heart, but it's like what's happening is, okay, you're pumping deoxygenated blood, but it's going to the lungs. Now, is that necessarily without harm? Well, that can also affect whether you're getting enough oxygenation and also determine blood flow to the lungs. But with the LAD and that Widowmaker heart attack, remember that your left ventricle has that very important job of pumping oxygenated blood to the rest of your body. So that's why it's the most serious type of heart attack, or myocardial infarction. So again, the LAD supplies over half of the left ventricle and over half of the interventricular septum. So if you're having this part of your heart dying, that's going to affect that pump function of that oxygenated blood to the rest of your body. Is it mostly men who get LAD infarction? Ooh, I should see about the distribution, about how, if there's a differences between the sexes in terms of where they tend to get the coronary vessels. That one I actually have to look up the stats for that one. Okay, so say someone does have an MI. So how does that affect your heart function? Does that mean you're going to die immediately? Thankfully, with modern, if you intervene fast enough, that's why time is very important to get, if you feel the symptoms of a heart attack, or a myocardial infarction, to get checked out, because the longer you have ischemia, the more cells that are going to die. But say you do have cells that die, how does your heart recover? So in terms of heart function, You have something called PostMi Remodeling. Now, do I want you to know everything about PostMi Remodeling? Not necessarily. But what I want you to appreciate is that over here we have an infarction due to ischemia. So these cells here are dying, and what we notice is that now this is our infarct zone. It no longer looks like this healthy myocardium and this heart walls over here. Now it's starting to thin and elongate, and we have a change in the overall shape of the heart as well. So notice that where there was healthy tissue before, it ended up being subjected to ischemia. Now it's being replaced by something called a fibrotic scar. And notice that the heart is getting bigger due to these heart muscle cells and undergoing hypertrophy. So we also have a bigger heart due to like trying to compensate for its damage. Now, ventricular remodeling, the thing is that when these dead heart muscle cells are cardiomyocytes, when they die, they are not necessarily replaced with new cardiac muscle cells. So it's not like when you work out your skeletal muscle and try to do bodybuilding where you try to break down your skeletal muscle to make it build it back bigger. Instead of being replaced by healthy muscle cells in ventricular remodeling after something like an MI, it's replaced by the fibroblasts. And fibroblasts are connective tissue cells, and they are going to secrete collagen. So this is not actin, this is not myosin. Collagen is very strong, but since it's not those contractile actin, myosin, thin and thick filament fibers, it's not going to contract. So it's strong, but it's not contractile. So what they are kind of like a patch. So the thing about this, like, okay, your heart is still intact, but this part right here, the scar, that doesn't contract. Only the muscle cells can contract. So this is why typically after a myocardial infarction, you have impaired heart function, because compared to the whole heart contracting in a healthy heart, now you have your heart is contracting, but there's a significant part of it that no longer contracts. So I like to liken, it's not exact analogy, but I think it's like this. Okay, we have damage somewhere. How are you going to patch it up? Because this is a tough thing about repairing your heart, is that your heart is also continually kicking around. So this is why heart surgery is also very difficult, because you're dealing with a moving target. So this is your body's natural way of trying to prevent your heart from blowing over, having this rupture of your heart, and trying to prevent this new scar and all these dead cells from causing all your, because again, this muscle is still going to contract. So this remodeling is important in maintaining the integrity of your heart so it doesn't blow itself out like this. Yeah, ventricular rupture. Yeah, that's deadly. Okay, so how do you treat it? Well, cardiac muscle regenerates, but now we used to say okay, it doesn't regenerate at all, but it's more like it regenerates very slowly. So it's not like doing bodybuilding or doing micro tears in your skeletal muscle. It can repair, but very, very, very slowly. So it depends on, okay, how much time was it between when you had the MI and that blockage and the ischemia, and how long was that ischemia for? Or was it multiple blockages? Was it a partial blockage? Was it complete blockage? So that also determines how much damage there is to the heart. And things like drugs and medications. If you have something like an anticoagulant or something that's preventing embolism, or something that's opening blood vessels or preventing the blockage, that may also help as well. And then things like angioplasty and stents, that helps, and something called a coronary bypass as well. Now, one of this is okay, because the cardiac muscle regenerates slowly, can we use something like stem cells to help regenerate healthy cardiac muscle? And this was has it already been, has it been already almost 16 years, 17 years? But yeah, Don Ho, there's statues of him, if you know, ask your parents or grandparents, they might know who Don Ho is. But yeah, he went under stem cell surgery, and I think he actually had to go out. It says Thailand. He actually had to go out of the country because it was very experimental. It hasn't really been proven clinically. But yeah, so I think he lived maybe a year or so after that, but he didn't live that much longer. But yeah, it was a hot topic at one point. And then in 2018, this Harvard researcher who was the leader in stem cell research in the heart, they found out that he pretty much like faked all of this data and coming from his lab. And this was like also it was very sus because a lot of people were like, oh well, trying to replicate his results, and they even got to the point like he had so much of these results that we actually had clinical trials in hospitals, so we were actually wasting millions of dollars based on this guy's, like, this guy was getting awarded money, but then researchers was like, we're not able to reproduce his results. It was really, really terrible. So yeah, he was like totally, he's ruined for life. And then yeah, it was like so many studies that were, and so many patients' lives that were affected because this was like they're being injected with or subject to this treatment that wasn't really working out for anybody. So it was like it pretty much set everything back. Now, does that mean stem cell research is totally bunk? Well, it just means like everything from his lab is bunk. So the good thing is that since the time since, like, that pretty much like, okay, we have to drop everything from this guy, and now but it's allowed other people who were like, and some of them were his greatest critics, like saying, hey, we're studying stem cells and we're not seeing the same things that he is producing from his lab. So one of the some of the other people who have stepped up and taken like now are, well, I don't know who would be considered the lead now, but they saw that, okay, you do see cardiomyocytes renewing, so there are stem cells, but it's not like myosatellite cells in skeletal muscle. Compared to that, like there are stem cells in heart muscle, but it's a very low rate, and 1% per year in young individuals, and as we get older, these start to drop off. So you can repair the heart, but very slowly. Now, we only have a limited amount of years on this planet per person, so is it going to, if you have a heart attack, are you going to repair it to 100% just naturally? So this is why stem cell research still needs to be done, because again, you don't have this natural repair occurring at a fast enough rate to repair everything. But what can we do since stem cell research is still a few decades off? Well, PCI is one of the common things. So what we have is like, okay, so if we didn't have this metal mesh over here, this is what we call PC angioplasty with this little balloon. So it's actually deflated here, and then we can inflate that balloon to open up a blood vessel. So that's what we call angioplasty. So using these balloons, it's referring to this blue part right here that's expanding that blood vessel that's slightly blocked off over here. Now, what you can use is, but typically they don't just do that anymore. Now they usually combine it with something called stents. So notice that the stent is it's really cool. Like if you ever seen one of these, like you can take the small stent, collapse it, and then unfold it in the middle of a blood vessel. And now that it's unfolded, it kind of locks in place and holds that blood vessel open. Let me mute it because YouTube is so terrible about like music copyright. Yeah, so that's what's happening here with this coronary stent. They're using a balloon to kind of unfold the stent and keep a blood vessel open. So that's, and even more modern stents, they might have like be coated with like a drug that prevents clots or prevents fatty plaques from accumulating on that same vessel, or keeps it from like maybe the vessel from building up tissue so it ends up closing up again. So that's why these stents are really useful, and it's rare that they do just plain angioplasty without a stent, because there was an increased chance of the blood vessel narrowing yet again. But stents help to keep it open. Very cool technology. So until stem cells get there, that's one of the main therapies we have. And things like you can use different veins, and there's also like left mammary vein as well, artery, yes. But this is one of the same main things that are used in terms of like helping to reroute the blood flow and go around this occlusion. Sometimes you can't open it with a stent and angioplasty. So what you can do is sometimes take another blood vessel from somewhere else and graft it and kind of do a little rerouting or redirecting or bypass. So that's what's happening over here. We have a bypass that's going from an artery, carrying all the oxygenated blood, and going around that occlusion and supplying the damaged area over here. So now you're going to have what we call perfusion, and you're delivering blood around that occlusion. So now this damaged area that's being subject to ischemia can have its blood supply restored. And yeah, this is like, okay, this is like a very terrible like place. I've never gone to it, but I remember seeing like back in maybe a decade ago that there's this place in Vegas, and I think the original was in Arizona, but it's closed down. It was called the Heart Attack Grill, and it's somewhere I think in Fremont Street in Las Vegas. And this is crazy. Like, this was their spokesperson, and he is like, and I don't know if they still have this. It was like their advertisement is like 350 pounds, eat for free. And they were like, they literally call themselves the Heart Attack Grill. And they have things like the coronary dog, the double, triple, and quadruple bypass burger. By the way, nurses do not dress like that. Like, that is like, that's like something you would see from a cosplay store. Like, nurses now, they all wear fake scrubs. No nurse dresses like that these days. Yeah, it's a pretty nasty restaurant for multiple. Like, there's a reason why it has like 3 point, or actually I think I saw Yelp as like 3.5. But yeah, here's the spokesperson. It's kind of crazy. But how's their spokesperson doing now? How's Blair River doing? Well, yeah, he's dead at 29. So it's like, whoa, what is that quadruple bypass? I mean, it's like, that didn't save him for sure. But yeah, that's crazy. Like, yeah. But what is a quadruple bypass? I know. So what is it, and what's this double, triple, and quadruple? The difference is, like, well, sometimes you have a heart attack and you can't do a PCI and you can't do a stent, so you have to do that single bypass. Now with a double bypass, what does that mean? Well, a double bypass means you have to do 2 of these. So now you have 2 blood vessel grafts. Then if you have triple, that means it's like you're going past here. And then now you have 3 of these grafts, and then quadruple bypass, then you have 4 of these. So yeah, that's why it's like, it's not just about like the severity of a heart attack, but also how many of this. I mean, could there be quintuple? There could be, but yeah, what you notice is now you're kind of getting all these like grafts, and it's like, this is why quadruple bypass is pretty serious as well. Alright, so maybe I will have to save this for next time, like in terms of the yeah. I might have to save this for next time. Yeah, in terms of recognizing the symptoms of myocardial infarction, it's very important because, again, when you have a myocardial infarction, what happens? You're not getting blood flow to your heart, and it's like suffocating. It's like, the longer you go without breathing, the worse it becomes, and you can eventually die, right? So that's why it's important to recognize the symptoms of a myocardial infarction. And yeah, and I agree. So it's like it's twisted how it's like, of course, and it's like is that there's so many things wrong with that heart attack grill. That's among many things, but yeah, the spokesperson dying at 29 is like, oof. I mean, I don't wish it ill on somebody, but that's hubris. I'll say that. All right, so thank you, everyone. Thanks to our moderators, and have a great 3-day weekend. See you all on Wednesday when we talk about recognizing how to have not how to have a heart attack, but how to recognize a heart attack. Because again, time is of the essence with recognizing a heart attack and intervening, so that you keep your heart, even though your heart is being damaged, you limit the damage as much as possible.